everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loupes that are built for you. Q Optics is more than magnification. Custom crafted through the lens loupes engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive TrueFit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized stress-free fit and all-day comfort. The Ergo Direct Vision loupes with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loupes for a straight-ahead gaze and complete ergonomic relief. And with crisp edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loupes and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Hi again, everyone. In this episode of the podcast, I'm really pleased to have as our guest Dr. Julie Hallet. Dr. Hallet is an associate professor of surgery at the University of Toronto and a surgical oncologist with a clinical practice devoted to hepato-biliary, pancreatic, and upper GI malignancies at the Odette Cancer Centre, Sunnybrook Health Sciences Centre. Her practice further focuses on neuroendocrine tumors as a part of the Susan Leslie Clinic for Neuroendocrine Tumors. Dr. Hallet is a chairholder of the Canadian Research Chair in Patient-Centered and Quality Cancer Surgery. Her program in health services research aims to improve the fidelity of care delivery in cancer surgery through access to quality care, high-performing team care models, and risk communication support, with a commitment to patient-centered research and equity. Dr. Hallet holds numerous leadership roles in many national and international societies, including being the current president of the Society of Surgical Ergonomics. Hello, Julie, and welcome to the podcast.
Thank you so much for having me. This is great.
My pleasure, of course. So, Julie, I was wondering if you would just tell our listeners a little bit about yourself, including kind of where you grew up and your training background and how you arrived at the current roles that I've just mentioned.
Yeah, for sure. So I was born and raised in Quebec City, in Quebec, so the French part of Canada. And I did most of my medical training over there. So I got into med school at a very young age, as we do in French Canada, and then did general surgery residency also at Université Laval in Quebec City. And during that time, I did a master's in clinical epidemiology to sort of learn research methodology, initially more so because I wanted to better understand the evidence I was applying in my day-to-day practice, but then eventually it became clear to me that I also wanted to develop that evidence and participate in the research endeavor. And then I moved to Toronto for a 2-year fellowship in surgical oncology. And so during that time, I did both general surgical oncology fellowship with an hepato-biliary track, which means that we spend the second year of the 2-year Surg Onc fellowship doing hepato-biliary and pancreatic surgery. So I'm certified in both of those specialties. And I initially was supposed to go back to Quebec City to practice over there. And there was an opportunity at the time in Toronto where I trained, and I applied for that position, eventually got it, which got me to start on staff at Sunnybrook and at the University of Toronto. And I've now been there for about 11 years.
Oh, wow.
Yeah, it's been a while. Just at the very beginning of it all, I went to France for a few months to Strasbourg to learn advanced minimally invasive surgery for liver and pancreas. So that was at IRCAD in Strasbourg, and then I came back to like my full-time practice after that. So yeah, it's a practice
Well,
that's mostly cancer, liver, pancreas. Cancer is also some upper GI, like gastric. And then because I do a lot of neuroendocrine tumors, I also do some small intestine resections as well.
well, Sunnybrook and U of T are very fortunate to have you, and I can say that being a former U of T alum myself. So,
That's true.
yeah, we have that part in common for our listeners. We've both done some part of our training at U of T. So, Julie, with all these areas of interest and your time spent in all these areas, I have to ask, how did you become interested in surgical ergonomics? I mean, I've shared how I became interested in it, so I was wondering if you could share that with our listeners as well.
Yeah, for sure. So thankfully I didn't have like I didn't get injured. Like I know your story and you've shared it with everybody. So I have to be thankful for that. But I was hurting in the operating room or at the end of a day in the OR and noticing that that made me sometimes want to avoid the cases where I knew I would feel in pain or made me like short-tempered with people when I knew I was in pain or when I was struggling physically and then cognitively as well, and that there must be better ways to do things. And then I think during the pandemic, a number of people were talking about it more openly on social media. And so, as you know, a group of us sort of started talking and then decided to take that off social media and get on sort of Zoom interest
Mhm.
group meetings, or even at the very beginning, almost felt like a support group type thing.
Yes, yes,
And
yeah.
then that evolved towards an interest group, and it evolved towards a society. And at the very beginning, from my perspective, I just wanted to like take the knowledge that others had
Mhm.
and that were experts in that field and try to apply it to my practice and maybe disseminate it within my hospital to make things better for others. And then eventually this sort of snowballs, right? Like you become
Mhm.
curious, talk with so many people and get excited about new ideas and want to see these things come to life. So then I started working a little bit more on some ergonomics research. But from my perspective, it's always been sort of my side thing, if you wish, although it's taking more and more space. Interesting how these things go.
Yeah, yeah, yeah. No, absolutely. And I really appreciate you sharing this with our listeners because I think, as you correctly pointed out, when we kind of started meeting on Zoom talking about physical ergonomics and something about cognitive ergonomics as well, I mean, it became apparent that this is an area of physician and specifically procedural physicians wellness that we weren't really paying attention to, and that people were, some were suffering in silence. Many had actually developed injuries and had to alter their practices, but many are like you, where, they kind of are accepting the symptoms as part of the job because that's what we're trained to do, right?
Yeah.
Just again to recap for our listeners, as Julie mentioned, the interest group then became not just a support group, it became more about, well, what can we do to improve things in our own spaces, as well as get a more broader awareness of the issues and share the work of people that had already been doing work in that area, like Dr. Susan Hallbeck from the Mayo Clinic. But then, Julie, as you said, things take a life of their own. And I know a huge interest of yours has been what we've now been calling team ergonomics. So I was wondering if you could share with our listeners, what prompted you to go from, kind of disseminating what we were already talking about versus really wanting to study this, and what did you find as you started actually designing studies to look into this a little bit more?
I think it's a whole process, like as you mentioned at the beginning,
Yeah.
it's more awareness and recognizing you're not alone in this, that it's not normal, but it's frequent to hurt
Yeah.
and to
Hmm.
be uncomfortable in the operating room. And it's not, you're not the problem. Everybody is in that situation. Second is learning that there's language around it, there's science behind it, there's data, and sort of learning that so you can learn the words and the information to talk about it with others and to advocate. And then third is learning the interventions that you can apply, you can use, and disseminate that. And to me, that's where things started to change a little, because I understood that there were evidence-based interventions that we can use, also some that are just common sense, quite frankly, but that was not happening in the OR. And it was a challenge, right? And so I was talking with different people in the operating room, and I'm close to a lot of the anesthesiologists at my center. And talking with them, they started saying, yeah, I feel the same. And this and that is a problem. And I had the usual reaction, I think, when I talk about this, when I gave talks of surgeons saying like, yeah, right, the anesthetists have ergonomics problems. Like, was your Sudoku too difficult today? And I'm being facetious, like on purpose. Like, I don't believe all they do is Sudoku. It's just to illustrate things. And sort of with talking with them, realize that they have some very unique ergonomic challenges and needs that we have no idea about. That sometimes what I do to make my posture or my setup better actually gets in the way of their ergonomics. And then same thing with the nurses as well, and the anesthesia assistants, and the PSPs and so on. And so realizing that, we're advocating for ourselves as surgeons, but we don't work alone in the operating room. And so ergonomics, like operating, is a team effort, right? And so we started talking about how can we then make this better from the perspective of the entire team. The first thing we decided to do is to, at least at Sunnybrook, stop talking about surgical ergonomics, because it has this feel of being about the surgeon, and talk about operating room ergonomics so everybody feels included. It's just, it's semantics, but to some people it matters a lot. And then we decided that maybe we all need to learn together how this works. And so the first project we put together is called the SOAR project. It stands for Simulation and Operating Room Ergonomics. So one of my colleagues in anesthesia, Dr. Fahad Alam, who's also part of the SSC now, is an expert in medical education and simulation. So he said, we could put people in a simulated environment, like in situ in an operating room, and all simulate together scenarios and see how we can set up ergonomics better, help each other, and not just learn in silos and then try to implement things for ourselves. And that's how this started. And this is a multi-step project where we first ran a survey. We surveyed all the operating room workers to ask, what do you know about ergonomics? What interventions are you using? Why and why not? And what are your perspectives on this? And second, what we are finalizing now is we ran interviews, because from surveys, you get sort of overall data, but then you read it and you're like, I want to know more about this part or that part. And you cannot do that with survey questions. You need to talk to people directly.
Right.
So we ran interviews, and the goal is really to identify what are the potential educational needs and then challenges in the operating room, so then we can build a curriculum and simulation for the entire OR team to learn better ergonomics. The survey was published in Annals of Surgery, and there's a medical student from the University of Ottawa now, Alexa Sma, who ran that, and she did a wonderful job with it. So there's lots from that survey. Essentially, what we learned is shocking. Everybody thinks ergonomics is super important, but they don't know how to do it. They don't have the knowledge.
Right.
When we listed all potential interventions, like, wearing appropriate shoes, compression stockings, anti-fatigue mat, and drop breaks, like hydration breaks during very long case, all these things, everybody thinks all these things are very important. Most of them are never used. And even the ones that are most commonly used are used less than 25% of the time. That's self-reported information. Right. We also learned that lots of people are in pain or uncomfortable, and that because of that, 1 out of 4 at our center has missed time and avoided coming to the operating room because of that. Wow. So that's huge when we're in a shortage of nurses. And then a lot of people actually are afraid of saying that they're in pain, what we noted. And some of the main barriers to being able to implement those interventions that they believe are useful, but they're not able to use, are they feel there's not enough support from leadership. We don't have ergonomic champions in each side. There's a lack of guideline. And then to me, what was most interesting is people fear the perception of others. They fear,
Indeed.
I don't have the quote, I should have looked it up before recording this, but they fear that asking for ergonomic adaptations or interventions will be seen as a matter of personal convenience and
Right.
as being difficult and being demanding, or as we've heard in some of the quotes, being a princess.
Or a diva,
Or a
yeah.
diva, or any of
Yeah.
those synonyms. You know,
Yeah.
one of the quotes said that the anti-fatigue mat was a unwieldy item of surgeon convenience. People don't want to have to deal with it, right? So just to me, that's where the team part is important, because if we each work on these things separately, we'll never be able to address this fear that people have or the misperception you have versus others. Really need to, number one, talk openly about it, make people know if we're in pain or if we have an injury that we need to look after. Right now, I have a few nurses that come to my OR that are unmodified, and they just say it at the beginning of the case, and so we know what they can and cannot do. We're never unmodified as surgeons, although we can talk about whether we should or not.
Right.
But
Right.
if we're injured, we should mention it so people understand why we do certain things certain way. We need to help each other better, and we need to learn how to do that. And we also found that out in the interviews. The analysis is still ongoing, but one of the key component is this sort of feeling that you're alone, that there's no communication, there's no collaboration around it. And then also that a lot of the solutions for ergonomics lies with the organization, lies with organization equipment, but people feel that the solutions they have to implement have to be individual. So they feel the barriers and the problems are organizational, and then they will find workarounds that are at the individual level to make up for it, because they don't think that these organizational things can be fixed, which is an interesting sort of dilemma, right? That we're trying to like dig a little bit deeper into.
Yeah, no, these are all such important findings and such important work, Julie. So I appreciate you sharing this. And actually, there's a lot to unpack. But one of the things that you said that kind of stayed with me, because in my head, I was able to kind of think about this conversation I had with Kristen Krauser a few weeks ago on the podcast about this very issue. And she did something similar at her institution. I mean, first getting a general lay of the land, right? Before you start to do things, you've got to figure out, is there a problem? You have a feeling there is, but how much of a problem? And what are the barriers? Because you might want to implement things that are evidence-based, but there are going to be barriers. And unless you address those, it's doomed to failure, right? And she said the same thing, that they were astounded to find, I mean, they expected their nursing staff and scrub techs to be in pain, but then they actually had higher levels of symptoms, work-related symptoms, often even whatever, even compared to what was reported by their surgeons. And if you actually look at the literature, 75% of hospital-based nurses report work-related musculoskeletal injury, very similar locations to surgeons. But a big hitter in that is operating room nurses, right? That's a unique group. I remember like looking at the numbers and, similarly kind of astounded. So that's one key thing that you brought up, and that's important to know and unpack. And then the second thing, among many others, is what you pointed out, what you're learning from the free kind of individual comments that came, with the surveys. One huge thing that you mentioned is this distinction between individual responsibility and organizational responsibility, and then people doing workarounds because they don't believe that the organizations will do anything differently, which is really kind of fascinating to me, because the very definition of ergonomics by the International Ergonomics Association says that ergonomics is the study of the interaction of humans with a system. And we're never going to be able to kind of quote unquote reach really good ergonomics without organizational involvement in the equipment that we deal with, right? So that could be the operating room equipment, instruments, beds, etc., but also this idea that this work-related stuff is the problem of the worker and not the organization.
Adapting the worker to the environment rather than adapting the environment to the workers, which is completely flipping around the principles of ergonomics.
But as I said, very definition, right?
Yep.
I guess I'm going to ask a little bit more. With this data, I know you've presented it at various meetings because I've heard you talk about it before as well. Were you able to take this data to leadership in your organizations or maybe even your societies, not just your own leadership at Sunnybrook? And how was this received? Because you involved all the key stakeholders, which is a huge thing, right? Not just saying this is something surgeons want, and as you said, surgeons being demanding and divas. This is an operating room problem, personnel problem in a time of shortage of surgeons and nurses in general.
We've tried, like we started for sure. I wanted to make sure that we had a good package to present, like a
I see.
nicely, package set of data with a big bow on it, because I find my experience when bringing things to leadership is often there's a million questions that sometimes have nothing really to do with what you studied, but
Mm,
you need to be able
hmm
to answer those or it gets relegated to another time. So I
hmm
like to have like a sort of complete assessments. I'd say we still have to present the whole package to our OR exec.
Okay.
There's lots of goodwill, right? Like, how can people be opposed to having their workers feel better and be safer, right? So, on the
Right.
principle, we always all agree. It's very hard to disagree. The
Correct.
struggle is like where the rubber hits the road is now we need to do something. We need to change our team models. We need to change our care organization. We need to change our scheduling. We need to change some of the equipment of the OR layouts. And the amount of inertia with change in anything, and in a healthcare in particular, is I don't even have a word for it. It's unbelievable, right? So even the things that
Mhm.
are the most common sense that you can think of take years to happen. So yeah, I find that there's goodwill. Now making change happen is a different thing, and we're still in that process. Like we don't really have that figured out yet. I'd say what I've tried to say, and when I give talks on this, that's also what I present is, just thinking about the circles of influence. Like there's your direct circle of control first, then you have your circle of influence. So things that you can interact with or try to influence. And there's a circle of worry, which is the outer layer where you have absolutely no control over. So I tried to like first work on what is like my circle of control. So that's the shoes I'm wearing, getting an anti-fatigue mat and setting it up for myself and asking anybody else to help me so it doesn't create trouble. Talking openly about ergonomics with trainees, with other OR workers, with people in my room on that day, getting myself new loops that are going to be better, all these things. And then the circle of influence that we're working right now, like trying to spread the word, talk with people, make change happen at the hospital level, can be also thinking about industry or other things. So that's where we're at. It's not very advanced right now, or there's a lot of work to be done there, but I'm trying to focus on those like circles of control so that, because it can become very depressing over time because you feel like you're not making changes, but if you look at those different layers of control, then you realize that maybe there's more control you have for certain things and certain things are changing, and you don't take as much on yourself for that other change to happen, if
Yeah.
that makes sense.
Yeah, no,
Yeah.
absolutely. I love that you just said this because I think my experience has been similar. There's a lot of goodwill. People are appalled to hear that their workers in the OR are in pain but when it actually comes to doing things, it takes a long time. It's not that change hasn't happened, as you said. I've seen changes happen. But I love this concept that you said. You look at the various circles, and it's really applicable to any kind of issue that we're dealing with, right? Whether it's getting your, certain kinds of equipment that you need, not even ergonomically related equipment, but just certain things. So you look at your circle and start where you have the most control. So surgeons, as you're listening to this, and anesthesiologists and nurses, in that OR environment, we're all stakeholders. And rather than getting discouraged, it's important to keep those lines of communication open. And maybe we can't make, the hospital buy all this sort of stuff or companies change all their instrumentation overnight. Those are things we can aspire to and are continuing to work on. And if you're interested in doing that, please look at the Society of Surgical Ergonomics, think about becoming a surgeon champion at your institution and reaching out to the people that have been on this podcast and will be on the podcast, because these are people who are moving and shaking and trying to kind of make things happen. But really, you can start in your universe, as Julie just pointed out, which is that one OR day, that one case that you knew was going to be taxing for everybody. If you can make that a little bit, make changes in that, that will go a long way. So I really, thank you for sharing that, because it suddenly got me thinking about all the other things I worry about and get angry about, and maybe I can just control certain things in my area of control.
Oh, listen, this is all like a
Yeah.
lot of theory, and I try to remember it, but I do get angry about a lot of things as well.
We're human. At the end of the day, we're human, and that's part of the human experience. And it's okay as long as we acknowledge that, right? For our listeners, I also want to ask you something that is near and dear to me, because when people when you're giving talks, I'm sure you are asked this question, because I certainly am. Well, these are all great, but how do these things that you talk about, evidence-based recommendations? How do you actually start to put them into practice so that it becomes a habit and doesn't interfere with workflow and all of these things? And many of us in the society have talked about doing an ergonomics timeout.
Mhm.
And I say, well, you can take these things and say, okay, and you just mentioned it, do I have my mat? Do I have, is the table at the correct height? Do I have my loops optimized? All of these things. But how do you incorporate that into the workflow? And I think I've heard you talk about this and others talk about this. And I think you've written an article too. And I will attach both your survey study that you mentioned in the Annals of Surgery, as well as this one that we're about to talk about, in the show notes. This concept of timeout means that we need a ergonomics timeout checklist. So tell me more about that and the work that you and others are doing to come up with this sort of optimal checklist, if you will.
Yeah, so we're working on that right now. It's again something that a lot of people at the society have talked about for a while, and at some point I'm
Mhm.
like, okay, let's make it happen, which is I feel has been sort of my role in surgical ergonomics. I'm not an ergonomist. Again, I'm a clinical epidemiologist. I do health services research, hepato-biliary surgery, but I hear all these things that people have ideas, and sometimes I know I can make things happen. So I'll just say, okay, I'll work with all of you, and we'll make your idea happen. So that's what's going on here. I'm saying that because I don't want to take any credit for the idea of ergonomics timeout. So many people have talked about it for a long time. And that article,
Agreed.
actually, you're going to put in the show notes. The first author is Andrew Gabrielson, who
Hmm.
went on this podcast, who now is not a resident anymore. He graduated last week,
Yep. Yep. Yep.
neurology
Yep.
at Hopkins. And he was talking about it a lot. He's like, I want to write something on this. So we tackled that together. Fahad Alam from anesthesia also helped us. And so this is kind of an opinion piece, really setting out what our intention is with the ergonomics timeout. And that comes a lot of what we talked about: communication, collaboration, safety can be improved if we can all have at least an opening to talk about ergonomics together at the beginning, during, or at the end of the case. Give this opportunity. So it's not only just to have some systematic items in there that will be implemented, it's also to create a space and a systematic way to talk about it as a team, which we felt was very needed based on our prior work. But we want to take a very systematic approach to this because there's different ways to do timeout. As you said, you have to integrate it in the flow of the ORs, that it doesn't disrupt everything or add 15 minutes, at the beginning of each case. So you have to be careful about this. And the way we're doing this is we're starting with a Delphi process. So consensus of experts from all around the world. And when I say experts for ergonomics, like any surgeon who operates, any nurse in the operating room, any anesthetist is an expert. You're an expert
Hmm.
at going through these issues. And so you don't have to be an ergonomist to be on that panel, is what we've decided. We also have some true ergonomic experts like health factor,
Hmm.
human factors researchers on there as well to support us. And we're just asking people to start by saying, write everything that you think should be part of the checklist. Any item, the timing, how we should do it, just write everything. And then we'll submit all of that through voting rounds to retain only the most important ones. And really starting from scratch, right? Like when we think about a checklist, everybody thinks about the WHO checklist that happens at the very
Hmm.
beginning and the
Hmm.
very end of the case. But for ergonomics, like some people have come to me and said, maybe we need multiple. Maybe we need like critical ergonomic time points during a case. And that's when we have like a 30 seconds checklist. And it's not only the one time. So there's a lot
Hmm.
of options available, but it can be things like disclosing injuries that each person has, making sure we have the right layout, we have the right equipment, and that includes anti-fatigue mats, it might include, the loop, setting up the intraoperative stretch, all these things. And again, this might happen before the patient even gets in the room, like a team huddle before we roll in the patient. So make sure the room is okay. There is different ways that we're able to do it. So we're open to all of that. But really the goal is to, yes, make a more systematic implementation of some interventions we know are evidence-based, but also create a space to talk as a team about ergonomics. And hopefully, if we create that space, people will feel more empowered to report problems, to say if they need adaptation during a case, to talk about how they're feeling and so on. Because one of the things we also found in our interviews is there's a lot of power differential in the feeling, the agency people feel they have in making changes or making ergonomic adaptation. And we don't solve everything with a timeout, but maybe just creating a space to talk about things can help with some of that. So that's the idea. And then once this is developed, we're going to see what the best format people want, like a sheet of paper, an app, or whatever, to run through it. And we're going to test it first in a simulation setting to see how it goes. And then once the sim one is approved, then we'll do test pilots in different operating room, different types of surgeries. It's going to run through centers in Canada, in the US, in the Netherlands, in Italy, and in the UK. So we have different health systems, different cultures, sort of thinking about this and seeing how it works. And then it will be adjusted at each step. That's it's a long process, but hopefully we get a good product at the end, because the WHO checklist is called the WHO safety checklist. Personally, I do believe there is no patient safety without OR workers' safety. And so that should be part of any checklist we have in the operating room.
Yeah, I agree wholeheartedly. And thank you so much for, taking on this work. I think your middle name needs to be Implementer, Julie Implementer, because, you have the expertise of clinical services research, right? And so developing something like this is very much in your tool belt. And that's kind of the other advantage of being in the Society of Surgical Ergonomics, where you have not only multiple specialty areas, right, to draw upon, sort of like the clinical specialties, I mean, in surgery and in anesthesiology, but you have this collaborative approach where people are willing to be able, get together and kind of make these things work. You mentioned and thanked Andrew Gabrielson, and I just want to alert our listeners that we did have Andrew as a guest, as you mentioned a few episodes ago. And if you're interested in learning more about the things that he's doing and did as a resident and will continue to do, as he becomes, I think, a pediatric urologist, he's about to start his fellowship, do take a look and do reach out to the Society of Surgical Ergonomics as well. Now, Julie, I'm always amazed how quickly time passes, as I say, when we're doing these episodes, but I would be remiss if I did not ask you about the unique ergonomic challenges you face as a hepato-biliary surgeon. I mean, there are some common challenges that all proceduralists face, but there must be some things that make hepato-biliary surgery, particularly what you do, more challenging. So I want to hear about what you found useful and what you impart to your current trainees. Just like when you did the fellowship, there are people doing, fellowship with you right now. What do you tell them about how they can preserve their career longevity? Anyone listening to this would be interested if they're particularly, doing hepatobiliary surgery. So.
Yeah, no, that's great. So there's three things I think about hepatobiliary surgery that are unique or particularly important at specialty. The first one is very long cases.
Yep.
So
big risk factor.
It's over 2 hours.
Yeah.
So that's a tough one. The second is loops.
Yep.
And loops to look deep in the body. So we often to bend our neck a lot.
Hyperflexion, second big risk factor.
Yep. And then third is the liver is a very well protected organ located like with retroperitoneal attachment behind the rib cage. It's there on purpose. It's very well, the body is smart, but we need to get it out of there. And to be able to do that, to be able to get the retrohepatic space, there is no way around contortioning our bodies and having a lot of back flexion and sometimes hyperextension. And those are horrible positions.
Yeah, non-neutral. Yeah.
And it's not avoidable, right? So I think the things I've learned is set things up well, intraoperative stretch break with the Mayo app from Stu Hallbeck, having the anti-fatigue mat, getting new loops. So I'm talking with the rep from a company for prismatic loops later today to get that done. And then after that is the posture reset. To me has been the most important thing. And I think I've heard that from Stu Hallbeck is it's okay. You're going to be in non-neutral position. You cannot avoid that. You will be in at-risk position. The most important thing is to not remain in prolonged at-risk position. So I have to get the liver out of the right upper quadrant, but then there's moments where I just need to reset, think about what the ideal posture is, resume that posture, and then go back into what I was doing. And just that to me has made a big difference. And what I try to do is when I do that, tell my trainees to do the same. I get them all to do the intraoperative stretch, and even like our fellow who just graduating added her own sort of squats to it because she feels like she did a lot of sports before, and for her from the injuries she suffered in the past, those help quite a bit. So she's made her own modifications to the stretch. And then I think so all these interventions I explained to them, they see me do it all the time. So that helps with the trainees. But what I felt is also talking about it openly. And I think that's a theme that I've taken through this entire podcast. You know, if trainees hear us say, my back hurts right now, I need 10 seconds, we're going to take a break for this or that reason, they feel like they can talk about it. It's okay for them to hurt as well. So just a quick example is the other day I was holding the portal vein in my left hand, and I had to reach for an instrument on the side with my right hand. I was completely twisted. When I untwisted, my back just blocked. It hurt. I had to finish the stitches I was doing because the portal vein was bleeding. I finished that. I made sure everything was okay. I let everything down. I said, like, I'm hurt. I just need to step off my step stool, take a second, and then come back. And nobody says anything. If anything, people were like, are you okay? And then when I scrubbed out, the senior resident said, thank you for doing that. And said, like, we know it happens to everyone. And so I think that just that can make a world of a difference.
Yeah, indeed. You know, I appreciate that you've kind of mentioned that multiple times during this episode. It's that, and also making an effort to incorporate that into the checklist, because as you said, there's no space for us to talk about these things. And if we can talk about them, then it kind of conveys the message to other members of the team that it's safe to do so and it happens to everybody, and what can we do collectively. So I think that's a piece that's missing currently from my personal checklist and workflow. So I'm going to add that to explain why I want certain things a certain way or why I'm stepping back. I do kind of mention, like you do, that oh my gosh, my neck is taking a beating. I need a few seconds.
Yeah.
And so everybody stretches back, and the students stretch, and I stretch, and everybody stretches. I didn't realize how much, you know, that could have an impact on just other people feeling comfortable to say it. But so now I'll make it more explicit that it's okay to talk about that. Well, we've come to the end of our time, and Julie, I just want to extend a huge, I should say, vote of gratitude for you for taking time out of your busy day. Thank you for letting me know that you're in clinic. So we got to let you get back to your patients. We caught up during this short break in your clinic. I look forward to continuing to work with you on the checklist and other things, to the symposium that you're going to be in charge of this year at the Society of Surgical Ergonomics. I'll give a shout out. Our symposium date is September.
But September 26th, it's all virtual. And our keynote speaker is going to be Dr. Theodore Grandshaw from Stanford, who will be talking to us about the OR black box and how with patient safety, but also worker safety efficiency. But thank you for having me. And I will extend to you as well gratitude for leading us through all of this and starting this interest group in the Society of Surgical Ergonomics and opening those discussions. I don't think that this community would be here without you. And so we owe you an immense amount of gratitude as well to bring us forward in this space.
Likewise, thank you. So with that, we'll end this episode. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. enter your name for the Ergo Angle Deflection Loops and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loops giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loops. Thank you.